Hi everybody, thank you very much. A lot of logos on here because you can't bring innovation anywhere without an enormous amount of collaboration. And mainly at the bottom, you've got one pharmaceutical firm there that supported us with intravenous busulfan. You've got a lot of charities that supported us, particularly in neuroblastoma, which I'm going to focus on. And of course, you've got Anchor at the top, which Jean-Claude's going to talk to us about. And then the various universities and places that we work that have to support what we do, because otherwise we couldn't do it. And Cancer Research UK, that really does fund most of our clinical trials, and CCC14, which is the international group supporting neuroblastoma research across Europe and beyond. So innovation, very much about people. People are at the heart of innovation always, but we put in place processes which try to help us. And I think one of the things about the UK and one of the things about the NHS is we have got fabulous nurses. There are some of the nurses here in the room. We've developed the notion of advanced nurse practitioners, nurse consultants, really nurses at a very senior level that can then come with us to international meetings and really share their experience with other people in other countries and teach actually other countries how to do things. Collaboration in clinical trials, which is really important, charities for funding, CCLG, going through the academic committees to get things accepted and prioritised, and of course pharma that in the end hopefully will either pick up the drug that we've made, which is one example I'm going to show you about, or producing the drugs which we can then use. And the Department of Health is crucial. We have to get all our clinical trials badged by the National Institute of Health Research, and then that means that they can be rolled out on the NHS using NHS resources, nurses, beds, and funding. And you can find all of these researches on the UK CRM portfolio database, and I went on it last night, and it's fascinating actually what's available and open for children with neuroblastoma in this country. Phase 1, Phase 2, Phase 3 studies, they're all on there. Bringing in tools, we've heard about imaging, proton therapy, which is going to open in the UK, I think it's 2017 now. Keyhole surgery to cause less trauma, the Human Genome Project that we're going to hear about in biology. Statistical methodology, which is really useful so that we can understand the results we bring together. And then a lot of data pooling, a lot of discussion recently in Washington and other places about using the cloud and getting a lot of data together so that we can really assess and learn more from the data that different people are producing in different areas. So I'm going to just give you two examples of how we have tried to bring in drugs. And I'm going to use an example of neuroblastoma where we've had really excellent international collaboration through CCC14. We've been trying to improve the outcomes for high-risk neuroblastoma, which is what Kathy was talking about, particularly these children with MECA amplification, and how we've been able to show in a study that high-dose therapy using busulfan and melphalan, which was pioneered in Europe, actually in Paris, is better than the American counterpart. And then monoclonal antibody therapy, which was being produced in America, being produced in Europe, and how we've tried to get it available for children in the UK. And then liver tumours, which is my other interest, and I'm going to touch on some of the things Bruce mentioned. The international collaboration there is with CCL, and in stunted disease, where we've got over 95% survival, we're reducing toxicity and trying to protect children from permanent damage. So first, neuroblastoma. This is a picture of one of our patients with Anne Keane, who was the Minister of Health at the time. And we were trying to get Anne Keane, after a lot of input from parents. I talk about parent power, and parents in neuroblastoma have had an amazing influence on what we've been able to do. But the ministers really clued up, and actually one of my colleagues and I went to Parliament for a debate on neuroblastoma and getting the antibody into the country. And so we do work very closely with the Department of Health and with our ministers. You've seen these curves before, but this is neuroblastoma, very high-risk disease, but in the UK, improved survival over the years. And this is CCC14, which I was president of up until last year. I'm now past president, where we've got a lot of people working together across Europe, also now New Zealand, Australia, some centres in Japan, etc., working together to try and improve the outcomes of children with neuroblastoma. What I think you can see from this is that the UK is a real leader in this area. Don't want you to worry about this slide, but for those of you maybe that are here who had treatment involvement with children with neuroblastoma. This is the sort of flow sheet we're using, very complicated induction treatment to start with. They then go on to get surgery. They then go on to get high-dose treatment, which we did a randomized study comparing, I don't know if it'll jump if I try to show you this with you. Oh, yes, that. So Boomel, that's the winner. This was the American one, that was the loser. And we then give them radiotherapy, and we go on to give immunotherapy, which is this one here, which is just closed, and where the UK had the largest number of patients in that trial. We were also able to bring in, thanks to Pierre Fabre, intravenous busulfan, which is less toxic than the oral. We were able to bring that into the UK in about 2006. And I have to say that if we can prove and show that something is better and safer, there is absolutely no reason why we can't bring it in to the UK. And this is high-risk neuroblastoma anti-GD2 treatment. It's immunotherapy, it's targeted therapy, it's a molecule that we had to actually make from the mouse, then put in human protein, which is why it's chimeric, it's mixed human and mouse, just the target bits of the mouse, so that the body doesn't reject it by recognizing it as foreign. And I just want to show you this. This is overall survival of children with high-risk neuroblastoma, and the top two lines are actually results of the American study when they first brought in, anti-GD2, which is the specific monoclonal antibody against neuroblastoma, and this is retinoic acid. They all get retinoic acid, which is a differentiation treatment in their maintenance phase. What I want you to see here is before we brought the antibody into treatment in the UK, the overall survival for children getting, it's quite difficult to get this arrow to work. Where is it gone? Oh, here it is. So Boomel, overall survival, children alive at 2 years, 75% of Boomel, which was the equivalent to the 75% for the children without the antibody in the States. So it's just that people get the impression, because of the way things are published, that potentially treatment in the States is better than here. It's very often actually not the case. There may be a specific treatment which is available here that's not available there, or a specific treatment that's available there that's not available here for a child in perhaps a relapse setting or a different setting. But on the whole, we're very fortunate that most of our treatments are actually developed and in sync with what's going on elsewhere around the world. This is just a picture of our CCL group. This was the meeting in Edinburgh, and for any of you who knew him, this was my predecessor, John Pritchard, who very sadly died a few years ago of a brain tumour, which I think is always tragic when you've got a colleague who you lose like that. And actually Liz Schaffer died just about a month ago, also of cancer. So we are not exempt as doctors, unfortunately, from cancer. You have seen this curve which Bruce showed you, and I think Cathy might have mentioned. Hepatoblastoma is the primary liver cancer of childhood. It's very, very, very rare. The only way that we were able to study this disease was by international collaboration, right back in the 80s. But what this curve shows is that as CCL, which is the name of the group, brought in its different studies, this is around the time of CCL1, and then we go up to CCL2 if you like, and CCL3, that we have managed, by collaborating with very rare disease, to bring real change. And these are the different CCL studies that have been running, and what I'm going to talk about is this one, which is CCL6, that I'm the international chair of, and we have now recruited almost the required number of patients. But in order to get that, CCL was founded in the UK. We have to get the money to run the study in the UK. We then have to get the money in all the other countries to run the study in their country, and then we put the data together. And this is just one of my favourite slides, because this is a child that was treated in my centre back in Belgium at the time where I worked, who benefited from the very first CCL study. And the CCL study decided that it was much safer to treat children with chemotherapy first, then take the tumour out, rather than try and take the tumour out first and then give the chemotherapy. And those of you that are familiar with Wilms tumour, you'll know that there was a study run in this country comparing early chemotherapy, then surgery, or surgery and then chemotherapy. But I had a little row with my boss at the time, who was about my size actually, he was quite small. But he was determined that this child should have upfront surgery because it was unheard of that liver tumours would respond to chemotherapy. And I won that argument because unfortunately the previous child had died at surgery. These are very hemorrhagic, bleeding type of tumours. This was the tumour, if you can imagine. It takes up almost all of the liver. There's this amount of normal liver left. Completely normal liver function because we can manage with very little liver. This is what happened when we gave chemotherapy. And the tumour was easily, safely removed. And this young man is now in his early 20s. This is the publication of SARPAL-3, which Bruce alluded to. He showed you two curves, one where they were using two drugs, cisplatin and doxorubicin, and another where we were able to show that using cisplatin alone was as good. What Bruce didn't mention, because he left it for me, is why we were so excited that we could leave out the doxorubicin. Doxorubicin causes cardiotoxicity. For children that need to have it, they need to have it, and we monitor them lifelong for heart problems and try and intervene earlier rather than later if their heart is struggling. But for children that don't need to have it, by removing doxorubicin from the regimen, if you can cure as many children without it, then you have no cardiotoxicity, no risk of heart damage. You do get left, of course, with the toxicity of cisplatin, which is a nasty drug, and which I've been studying since the 1980s, and produced a classification of the hearing loss. Children get permanent, high-frequency hearing loss with cisplatin. So we produced this grading system to see whether they had minimal, mild, moderate, marked, or severe hearing loss. And we've brought this grading system into the current trial so that we've got a marker to compare whether if we bring in a drug, and this is an old drug, it's the drug always used and available right across the world for cyanide poisoning. And I appreciate there's not a lot of cyanide poisoning around anymore, but all fridges in all hospitals across the world had to have this drug STS, which is sodium thiosulfate. And sodium thiosulfate was discovered when it was used in a lecturer who was having treatment with carboplatin for a brain tumour and didn't want to go deaf. Her husband discovered that STS might help. She got the STS, she's still lecturing, she didn't go deaf. And we are now doing a randomised study. This is a typical sort of diagram of a trial where they either get CDTP as a shortening for cisplatin. They either get cisplatin alone, which we know will cure them, or they get cisplatin and STS, which we hope will prevent them going deaf. And that study is ongoing. We've got 103 patients in the study as of yesterday. We need 102 evaluable. It's taken 8 years to collect that data. And hopefully we will have enough patients evaluable soon to close that study. So thank you so much for inviting me to come. 10 minutes is not long.
Are there any questions for Becky?
Can I just ask a question? Yeah, how do the parents groups help you?
Okay, parents, particularly neuroblastoma, are very, very active. So they have produced a large number of charities. As Ashley was talking about earlier, we have small charities and large charities. We have been supported by all of them. We've had a number of sort of collaborative days to get the different charities supporting neuroblastoma research and parents with children with neuroblastoma in the room together so that we can talk to them about what's really important. They have influenced, when necessary, their Member of Parliament. So Mr. Bone was the one who took to Parliament the discussion about the antibody that was not available yet in the UK, and we were having to send children to Germany for the antibody that we had produced and we had paid for, but was being piloted in a centre in Germany. And what we wanted was funding to really support those children going to Germany, It wasn't ready at that stage to open it up in all centres, and that will always be the case. Wherever you have a pioneering centre, take Bristol with their wonderful mini capitals, you can't spread that immediately across the UK because you've got to have the equipment, learn the technique, you've got to train everybody up. And what you can do is pay to send people to Bristol. Now, in the UK, we can do that, but there's probably somebody who wants to come from outside the UK to get that treatment, and they will need to be funded to be able to do that. So the parents have supported the understanding. They made the government, I think, aware, so that in the end, we were sitting down and talking to Smythe Richards, who at the time was the councillor, working out what we could do.